It's Dr. Mohib, and in this lecture we will be going through lipid disorders like Abetalipoproteinemia, familial dyslipidemias, and at last some memory drills. So first of all, Abetalipoproteinemia. As the name implies, A for absence of beta lipoproteins. So what are beta lipoproteins? Apolipoprotein B48 and B100 are known as beta lipoproteins. These apolipoproteins are required by the lipoproteins for their secretion from intestines and hepatocyte. B48 is required for secretion of lipoproteins from intestines, while B100 is required for secretion from hepatocytes. B48 or intestinal lipoprotein is chylomicron, while B100 is for VLDL and LDL. IDL after being modified becomes LDL. So what happens in Abetalipoproteinemia? There is absence of beta lipoprotein. Since there is no beta lipoprotein, so these lipoproteins will not be secreted. Thus we have absence of chylomicrons, VLDL and LDL. These lipoproteins play a crucial role in lipid transport. The chylomicron is the exogenous lipid transport lipoprotein, while VLDL and LDL are endogenous lipid transport lipoproteins. Chylomicron transports triglycerides, cholesterol, esters and fat soluble vitamins. So these patients will have deficiency of these things. The pattern followed by Abetalipoproteinemia is that of autosomal recessive. It is inherited in autosomal recessive pattern, and the cause for Abetalipoproteinemia is due to the mutation in gene that encodes microsomal transfer protein or MTP. What is the job of MTP is that it forms and secretes lipoproteins with apolipoprotein. So as a result, chylomicrons, VLDL and LDL are all absent. There is deficiency in ApoB48 and ApoB100 containing lipoproteins. So what are the symptoms? The affected infants will present with severe fat malabsorption, steatorrhea and failure to thrive. Since chylomicrons play a crucial role in exogenous fat absorption, so this patient will have severe fat malabsorption, steatorrhea and failure to thrive. The later manifestations include retinitis pigmentosa, which is a retinal disorder, as well as spinocerebellar degeneration due to vitamin E deficiency. Vitamin E is deoxidant, or it detoxifies different oxidants within our body. So what happens in spinocerebellar degeneration is that the tracts carrying the proprioceptive signals from the periphery or different parts of the body to the cerebellum, this pathway becomes degenerated. Since cerebellum is the regulatory organ or regulatory body of our balance and position, so since the pathway or input to cerebellum becomes disrupted, so this patient will have progressive ataxia or loss of balance, as well as acanthocytosis, which is the disorder of RBC membrane. The symptoms are simple, remembered by 3S of Abetalipoproteinemia. The 3 S's are steatorrhea, spinocerebellar degeneration leading to ataxia, as well as spiky RBCs, also known as acanthocytes. So the intestinal biopsy will show lipid-laden enterocytes shown in arrow A. Since the fats or these exogenous fat become entrapped in enterocyte, the exogenous fat coming from our diet enter the enterocyte, but since they cannot be secreted via chylomicrons, they get entrapped within the enterocyte, forming these lipid droplets within the enterocytes, which is a characteristic feature of Abetalipoproteinemia. And the treatment is restriction of long chain fatty acids as well as large doses of vitamin E. There is deficiency of all the fat soluble vitamins A, D, E and K, and R should be replaced, but vitamin E is the most notorious, or the symptoms caused by the vitamin E deficiency are the most dangerous for these patients. So they should be replaced by large doses of vitamin E, as well as these patients should be restricted of long chain fatty acids. The long chain fatty acids follow the typical pathway of fat absorption, where the exogenous fats enter enterocytes, where they are packaged in chylomicrons and secreted with ApoB48. Then they enter the lymphatic system and finally reach the systemic circulation, while the medium chain fatty acids containing from 6 to 12 fatty acids usually bypass this pathway and go directly through enterocyte. They are somewhat, or they have a little bit of water solubility, so they pass through enterocyte and enter the systemic circulation via portal vein, where they are bound with albumin and reach their target organ. So the long chain fatty acid should be avoided in these patients. Then we have acanthocytes. Acanthocytes is also a characteristic feature of Abetalipoproteinemia. It is present in liver disease as well as Abetalipoproteinemia and vitamin E deficiency. In acanthocytes, also known as spurs, we have projections of varying size at irregular intervals. The acanthocytes are asymmetric. If we look at over here, there are varying amounts and sizes of projections coming off the membrane of RBC. The reason is due to the irregular handling of or abnormal lipid within the body. The RBC membrane consists of double membranes. In abnormal lipid transport or lipid content of our body, the outer membrane grows more than the inside membrane. Thus, there are these spikes formed on the RBC membrane. And then we have a retinal condition, also a characteristic feature of retinitis abetalipoproteinemia, which is retinitis pigmentosa. It is a group of inherited dystrophies causing progressive degeneration of photoreceptors and retinal pigment epithelium. It may be associated with abetalipoproteinemia, and the early symptoms are night blindness. So these patients will have night blindness as well as peripheral vision loss. On fundoscopy examination, there is a triad of optic disc pallor, retinal vessel attenuation, and retinal pigmentation with bone spicule shaped deposits. The characteristic feature of these disorders is this bone spicule shaped deposits. If you look at over here, the arrow showing these are the deposits in the retinal epithelium. These deposits, which is a characteristic feature of retinitis pigmentosa. So this was all about abetalipoproteinemia. Then we have familial dyslipidemias. Familial dyslipidemias are a group of inherited genetic disorders characterized by abnormal elevation or handling of lipids and lipoproteins in the blood. They are typically caused by single gene mutations affecting key proteins, receptors, or enzymes involved in lipid metabolism. So as a consequence, these patients will have levels of higher content or high levels of lipids. So these patients may experience high levels of TGs or higher levels of cholesterol or both. And one thing to remember is that there is no disorder or there is no condition where there is isolated levels, high levels of triglycerides or higher levels of cholesterol. There is some portion present of either the lipids, but there are certain diseases in which there is characteristically high levels of triglycerides, and there are certain diseases in which there are characteristically high levels of cholesterol with some portion of the other lipid too. Now, what are the signs of hyperlipidemia? Since these patients have higher lipidemias, so the signs of hyperlipidemias are as follows. So these patients may experience xanthomas, tendinous xanthomas, or corneal ulcers. So when the lipid content of our body increase, these high levels of lipid deposit in different parts of our body. So when plaques or nodules composed of lipid-laden histiocytes deposit in skin, they are known as xanthomas. So xanthomas are plaques or nodules composed of lipid-laden histiocytes in skin. These are xanthomas. And when, especially the eyelids, and when they are present on eyelids, they are known as xanthelasmas. And these are xanthomas are present in skin. They can also deposit in Tendons. So lipid deposit in tendon known as tendinous xanthomas, especially the Achilles tendon and finger extensors associated with familial hypercholesterolemia. So these are finger extensors, tendinous xanthomas. Then we have corneal arcus, which is the lipid deposition in cornea. It is common in older adults, also known as arcus senilus, but appears earlier in life with hypercholesterolemia. If you look at over here, this white rim in cornea is actually the lipid deposition. This white rim is the lipid deposition within the cornea. So this all about corneal hyperlipidemia sign. Now we have the levels of the normal ranges of different lipoproteins as well as the lipids level. So the easiest way to remember the levels is the 50 or the multiple of 50 rule. 50, 100, 150 and 200. So the normal level of HDL should be above 50 for female and above 40 for male. So 50 higher levels of HDL, since HDL is the healthy lipoproteins which plays a key role in reverse cholesterol transport, so the levels should be above 50. Then we have LDL. The levels of LDL should be lower than 100. Then we have triglycerides. The level of triglycerides should be lower than 150, or in other words, the upper limit for triglyceride is 150, for LDL is 100, and for total body cholesterol it is 200. So the levels of total body cholesterol should be less than 200, and the minimum level of HDL is 50. So this was about the levels of different lipids in our body. Then let's come toward the consequence of higher levels. So if we have higher levels of triglycerides in our body, the mnemonic is TGs. T for triglyceride is toxic to tissues. So higher levels of triglyceride causes acute pancreatitis. The mnemonic is it is toxic to tissue. The reason is that triglyceride is carried by large size lipoproteins like chylomicrons and VLDL. These are chylomicrons and VLDL that deliver triglycerides, which are large in size. So since when the body has high levels of triglycerides or higher levels of chylomicrons or VLDL, they block the capillaries of pancreas. These blocked capillaries causes ischemia, leading to activation of pancreatic lipases. These activated pancreatic lipases converts the triglycerides into free fatty acids. These higher levels of free fatty acids are toxic to the tissues of pancreas. It not only damages the pancreatic acinar cells as well as activates the zymogens or the precursor enzymes present in the pancreas or the pancreatic juice like trypsinogen. So as a result, there is autodigestion of pancreas, leading to widespread inflammation in the pancreas. So this was the mechanism. The free fatty acid also causes the pancreatitis. So the high levels of triglycerides lead to acute pancreatitis, while higher levels of cholesterol, the mnemonic is it causes chronic, C for cholesterol and C for chronic clogging. The higher levels of cholesterol are associated with atherosclerosis. It leads to the clogging of arteries. So if we look at the medium and large sized elastic arteries, the higher levels of the LDL, which is the carrier of cholesterol, they break the endothelial membrane and enter the innermost layer of arteries, where they are oxidized, and the oxidized LDLs recruit monocytes, converting them into macrophages. These macrophages then secrete cytokines, leading to the muscle deposition as well as the sealing of this necrotic or this lipid core with fibrous cap. So there is fibrous cap over here, sealing of the necrotic, this high lipid core. This is the lipid core, and this is fibrous cap. So what is the consequence? We have decreased size of lumen of arteries, leading to atherosclerosis. So these atherosclerosis will present as either peripheral arterial disease, or if the fibrous cap breaks off, it will lead to MI or stroke in the affected individuals or patient. So this was all about the higher levels of cholesterol in our body, the effects of higher levels of cholesterol. Now let's coming towards the different types of familial dyslipidemias. There are 4 types: 1, 2, 3 and 4. Type 1 is hyperchylomicronemia, type 2 hypercholesterolemia, type 3 Dysbetalipoproteinemia, 4 hypertriglyceridemia. The inheritance pattern is that 1 and 3 follow autosomal recessive pattern, while 2 and 4 follow autosomal dominant. The easy way to remember is that D of dominant, since it is the 4th alphabet which is even number, so those disorders which are even number are autosomal dominant. So type 2 and 4 are autosomal dominant, and since R is odd number alphabet, so the odd number alpha disorders like 1 and 3 are autosomal recessive. Then coming towards the levels, so type 1 has higher levels of triglycerides with some levels of cholesterol, but the symptoms are due to the higher levels of triglycerides, as well as type 4. In type 4 we have higher levels of triglycerides, and in type 2 and type 3 we have higher levels of cholesterol. So these patients will experience symptoms of higher levels of cholesterol. Then which lipoproteins are elevated in these disorders? The mnemonic is clever, the clave of clever. One should be clever to remember this disorder. So C for type 1 or chylomicronemia, C for chylomicrons. Then we have L. So in type 2 we have higher levels of LDL. Then type 3 is for E, or entrapped remnants. So those remnants which cannot be taken up by our body, which include chylomicrons, VLDL. And then we have V for type 4, in which we have higher levels of VLDL. Now let's discuss each disorder thoroughly. So first of all we have type 1 hyperchylomicronemia. It follows the autosomal recessive pattern since it is odd number or 1. The main concerning symptom is that these patients have lipoprotein lipase deficiency or ApoC2. Since ApoC2 is a cofactor, so these patients will have higher levels of both TGs as well as cholesterol. If we come over here, these are chylomicrons and these are VLDL. For their transport, or lipoprotein lipase is required for their transport of triglycerides, and the cofactor required for this is ApoC2. So in these individuals, either lipoprotein lipase is absent or ApoC2 is absent, so there is no transfer of triglycerides in chylomicrons as well as VLDL. VLDL also carries the or transports the triglyceride, the hepatic triglyceride, using same lipoprotein lipase as an enzyme and ApoC2 as a cofactor. So these patients will have high levels of VLDL as well as chylomicrons, but specifically the levels of chylomicrons are heavily elevated, and the lipids present in chylomicrons are triglycerides which are specifically affected. So these patients will have high levels of triglycerides as well as some amount of cholesterol. So these patients will experience pancreatitis due to high levels of triglycerides, also hepatosplenomegaly and eruptive or pruritic xanthomas, but there is no increased risk for atherosclerosis. There is a creamy layer in supernatant. If we take blood of these patients and put it in a test tube, there will be a creamy layer formation showing the higher levels of TGs. Then we have type 2, also known as hypercholesterolemia. Since it is even number, so it follows the dominant, and C for chylomicronemia, L, the clever L for type 2, in which we have high levels of LDL. The affected individual either have absent or defective LDL receptors, which is type 2A, or defective ApoB100, which is type 2B. So in type 2A we have high levels of LDL and high levels of cholesterol, while type 2B we have high levels of LDL, cholesterol as well as VLDL, because ApoB100 is also present on VLDL too. So these individuals, if there are heterozygotes in which the individual carry only one dominant or one gene is mutated, which is present in 1 out of 500 individuals, so they have cholesterol level up to 300, while the normal level is less than 200, and homozygotes which carry both the defective genes, which is very rare, have cholesterol levels up to greater than 700 milligram per deciliter. So these patients experience accelerated atherosclerosis, may have MI before age 20, and tendinous Achilles xanthomas and corneal arcus. Then we have type 3 or Dysbetalipoproteinemia. It is third one, so it is odd number, so autosomal recessive, and E for clever mnemonic, in which there are entrapped remnants are increased. The main pathogenesis is that these patients have defective ApoE. Defective in type 3 you can remember for as this mnemonic too. So since ApoE is required for hepatic uptake of the remnants of chylomicrons and VLDL. So these patients will have high levels of chylomicrons as well as VLDL, and these patients will have higher levels of cholesterol as well as triglycerides. So these patients also experience premature atherosclerosis, tuberoeruptive and palmar xanthomas, but the risk for premature atherosclerosis is less than type 2. The highest risk for atherosclerosis is present only in type 2. Then we have type 4, also known as hypertriglyceridemia. Since it is even number 4, so it follows the inheritance pattern as autosomal dominant, and V for VLDL of clever. So the main pathogenesis is that in these individuals there is hepatic overproduction of VLDL. So VLDL is the main endogenous transporter of hepatic triglycerides as well as cholesterol, but the levels of triglycerides are very high. So these patients can experience hypertriglyceridemia up to greater than 1000 milligram per deciliter and can cause acute pancreatitis. Another key thing to remember about type 4 is that it is also related to insulin resistance. It is a high yield tie over here. When the high levels of TGs, when they exceed 1000 milligram per deciliter, then it causes acute pancreatitis. So it was all about Abetalipoproteinemia and familial dyslipidemias. Now let's switch toward memory drills. Number 1. Abetalipoproteinemia is caused by mutation in the gene encoding ApoE, ApoC2, microsomal transfer protein, or LDL receptor. And the correct option is microsomal transfer protein. Then type 2 hypercholesterolemia is inherited as autosomal recessive, dominant, X-linked recessive, or multifactorial only. Since it is type 2 and type 4 follows autosomal dominant, so it is the autosomal dominant disorder. And then at last, type 1 hyperchylomicronemia is caused by deficiency of LDL receptor, ApoE, lipoprotein lipase, or ApoC2 or ApoB100. And the correct option is lipoprotein lipase or C2. Thank you.